Okay, so I'd like to start off our presentation today. But I will first introduce our speaker, Dr. Chamie, Associate Professor Urology at UCLA. Initially underwent medical school at USC. After completing his urologic training at UC Davis, he finished an SUO fellowship in urologic oncology at UCLA. He remains there now with primary research interests focused on health services research, clinical trials, and bladder, with clinical interests covering all of urologic oncology, but with a particular interest in bladder cancer and robotic surgery. So with that, I'll hand it over to him to go over our topic for today.
Awesome. Thanks, Sam. Good morning, everybody. I have a lot to get through, so I want to get started and talk to you a little bit about BCG unresponsive bladder cancer. You guys can all see my slides okay? All right. Here's the outline. First, I'm going to talk about a little bit about burden of bladder cancer, not so much survival, but more the impact of recurrences and progression in patients with high-grade bladder cancer. We'll then go over some data about BCG efficacy. We'll define what BCG unresponsive disease is. We'll go over some of the existing therapies, some of the clinical trials, and of course, we can't forget radical cystectomy. So a little bit about burden of bladder cancer. Everyone talks about 5-year survival rates for patients with bladder cancer being something on the order of 80 to 90%. But what they kind of miss is that the vast majority of patients who have high-grade bladder cancer tend to have a lot of recurrences and progression. This is a paper that I published about 7 years ago, looking at patients with high-grade bladder cancer. If you look at a cohort of 7,400 patients, these are Medicare beneficiaries, 65 years of age or older, who are diagnosed with bladder cancer. Out of the 7,400, what you'll see is that if you follow these patients for 4.5 years, only about 1,000 patients are alive without any recurrences or progression. So you got, 6/7 of this cohort that end up either dying, having recurrences, or progress to muscle-invasive disease. Now, if you look at when they recur, when they progress, and when they die, you'll see the vast majority of the recurrences occur in the first 2 years. So the 2-year recurrence rate for patients with high-grade bladder cancer is about 61%, and it tends to level off after that. That's why our surveillance strategies tend to be so intense in the first couple of years. So at 5 years, it's 69.5%, and at 10 years, it's about 74%. If you look at progression, it doesn't actually plateau off. So every few years, it tends to continue to go up by 10%. So at 2 years, it's about 13. At 5 years, it's about 23%, and at 10 years, it's about 33%. And as far as mortality, at 2 years, it's 6.5. At 5, it's 10, and at 10 years, it's 12%. So these patients with high-grade bladder cancer do have a long-term risk of progression. What about some of the efficacy data that we have for BCG? First, we know that patients who have carcinoma in situ, the complete response rates from BCG are about 80%. The problem is that most patients, at least if you look at some of these historical series, will end up recurring within 5 years. So within a year, 50% of patients will recur, and up to 90% of patients will recur within 5 years. And half of those will progress. Now, there was the SWOG study that looked at maintenance BCG, and this is something that most people here know quite well. For the residents who take the in-service exam, you got to memorize the SWOG treatment patterns as far as when they get their installations. But what you also notice is that patients who got maintenance therapy did significantly better with regards to recurrence and progression-free survival. There was a trend towards improvement in overall survival. Unfortunately, only 16% of patients completed all full 8 courses. Now, there have been other studies that have looked at BCG. There are a number of studies that compared intravesical BCG and compared it with intravesical mitomycin C. And if you look at these 4 studies, what you'll notice is that in studies where patients did not get maintenance BCG, mitomycin C actually outperformed BCG therapy. In patients who did get maintenance BCG, however, BCG tended to outperform mitomycin C. And here are the Kaplan-Meier curves. So you'll see on the top left corner, patients who had BCG with maintenance. The blue line here is BCG outperformed mitomycin. And in patients who did not get maintenance therapy, the red line, which is mitomycin, outperformed BCG. Now, this was present even for those who've had no prior chemotherapy and BCG, or those that have had prior chemotherapy or BCG. Patients who get BCG with maintenance tend to outperform mitomycin C therapy, irrespective of prior intravesical therapies. Now, what if a patient recurs after an induction course? What do? The board answer is you re-challenge them with a second induction course. And this is based on a number of studies that have actually looked at this. So you'll see that about 35% of patients who have failed a prior induction course of BCG therapy will respond to a second course of BCG therapy. However, further intravesical therapy courses have no benefit. Bill Catalona, before he limited his practice to only prostate cancer, actually studied this and found that for every extra course of BCG, there's a 7% increased risk of progression. Now, let's talk about BCG unresponsive disease. And so before we actually had a definition of BCG unresponsive disease, we as urologists actually broke down the definition of BCG failures into BCG refractory, resistant, relapsing, and intolerant. BCG refractories tends to be associated with worse outcomes. These patients are those that are given an induction course of BCG, and evaluating them 6 months later, they still have carcinoma in situ or papillary disease. BCG refractories, also patients that say may have had TA, high-grade TA or CIS initially, and you give them an induction course of BCG, and at 3 months you go in there and you find that they have high-grade T1. So even though they don't receive any additional therapies up to 6 months, the fact that they've progressed from high-grade TA or CIS to T1 makes them BCG refractory. BCG resistant are patients who have persistence of disease at 3 months after an induction cycle. But sometimes if you look at them at 6 months, they have a lower grade or lower stage after 6 months therapy. BCG relapsing is probably the most common. These are patients who initially respond to BCG, to the induction course and maintenance course. And if you follow these patients, they may recur within 12 months, 12 to 24 months, and more than 24 months. So if they recur within 12 months, they're early relapsers. If 12 to 24 months, they're intermediate relapsers. And if they relapse more than 24 months later, then they're late relapsers. BCG intolerant are those that are unable to tolerate it secondary to adverse effects. Now, we've since actually come up with a more defined approach towards classifying patients with BCG unresponsive disease. And now what we classify it as any patient who has persistent or recurrent carcinoma in situ alone or with Ta/T1 disease within 12 months of receiving adequate BCG therapy. What adequate BCG therapy means is they've received at least 5 of 6 induction courses and 2 or 3 maintenance courses. It also includes patients who have recurrent high-grade disease within 6 months of completing BCG, and those who, again, may have gone from TA or CIS up to T1 after the initial 3-month induction. Now, what do the AUA and the AU guidelines offer? Well, they tell us that the standard of care is still a radical cystectomy for patients with BCG unresponsive disease. But you may be able to offer clinical trials for those that may be too old or too frail to undergo this aggressive treatment. So what do we have available to us? Well, some of the earlier work was done by Mike O'Donnell. And in this study, it was a phase 2 study where everybody was given interferon alpha. And what these patients were given was a third dose of BCG plus 50 million units of interferon alpha if they were able to tolerate BCG well. If they were BCG intolerant, then they got a 1/10 of a dose of BCG plus 100 million units of interferon alpha. And then these patients were given 3 weekly installations of interferon alpha and BCG at 3, 9, and 15 months. And you'll see here, it's not as though we're comparing BCG to BCG interferon. Everybody here got BCG plus interferon. But you'll notice is that the patients who are BCG naive ended up outperforming those who failed prior BCG. So if you look at 2 years, 59% of the patients are recurrence-free for the BCG naive, and 45% of those who failed prior BCG therapy. Now, they also did a multivariable analysis and found that other predictors of increased risk of recurrence was if the tumor was greater than 5 centimeters, if it's multifocal, if they were BCG refractory, if their recurrences were less than 12 months, or if they had T1 disease compared to TA. But what you'll notice is that patients who recur more than 12 months actually do no different than patients who are BCG naive. That's why if a patient recurs more than 12 months later from receiving any BCG therapy, we in essence think of them as BCG naive. Now, they also looked at other predictors, and so they found that patients who had TA disease, their 2-year disease-free survival was 35%. For those with CIS, it was 24%. Time to relapse, so if they were BCG refractory, it was 34%. If they're early relapsers, it's 41%. If they're intermediates, early relapses were 41 to 43%. If they're intermediates, it's 53%. And if they're late relapsers, their recurrence-free survival at 2 years was 66%. So they, when they recur is based on not only their tumor biology, but also their recurrence pattern. If you look at who benefited the most, you'll see that, on the bottom lower hand corner, you'll see that patients who are BCG naive tend to do better than those who recur more than 12 months, and those who recur less than 12 months tend to do the worst. Unfortunately, interferon is unlikely to be available in the future. And so while that's a little sad, you have to realize that most physicians weren't actually using interferon. And there is a new therapy that actually harnesses the power of interferon towards BCG unresponsive disease. And I'll talk about that a little later. So what are some of the other existing therapies? You have valrubicin. There was a phase 2 study and a phase 3 study. They both looked at patients who have failed prior BCG therapy. These are, again, heavily pretreated patients. They've received 6 weekly installations of valrubicin, 800 milligrams and 75 milliliters of saline. The complete response rate were initially around 30%, but at 6 months, it was around 21%. At about a year, it was around 10%. And if you follow these patients out to the end, it was around 8%. More than half of the patients ended up undergoing a cystectomy, most of who were non-responders. 4% of patients ended up dying of bladder cancer. So what are some of the other existing therapies? You've got gemcitabine. This is an Italian study that looked at gemcitabine versus BCG for patients who failed prior course of BCG. The way it was given is they were given twice weekly installations of gemcitabine, which is a little unusual. We don't usually give it that often. And it's given for 6 weeks, followed by 3 weekly installations at 3, 6, and 12 months. It was compared against 6 weekly courses of BCG, followed by 3 weekly installations at 3, 6, and 12 months. And what you'll see is that the median recurrence-free survival is 13 months for those who got gemcitabine and 7 months for those who got BCG. If you follow these patients out to 2 years, you'll notice that that 19% of patients are disease-free at 2 years with gemcitabine versus 3% with BCG. They also compared gemcitabine to mitomycin. This is a different study in 2010 published in JCO. Here what they did was they gave patients who failed a prior course of BCG or epirubicin, and they're randomized to either gemcitabine or mitomycin. Of note, none of the patients here had carcinoma in situ. Again, these are only patients with papillary disease. What you'll see is that gemcitabine outperformed mitomycin C. The median recurrence-free survival was never reached for the mitomycin C, and it was 15 months. Never reached for gemcitabine, and was 15 months for mitomycin C. If you look at patients with high-grade disease, again, gemcitabine outperformed mitomycin C 22 to 33 months. So gemcitabine definitely has a role in this disease state. Isla Skinner also published a paper about 8 years ago. It was a SWOG study, 47 patients who failed 2 prior courses of BCG. They either had CIS, T1, high-grade TA, or low-grade TA with more than 2 lesions. They were treated with gemcitabine, 2 grams and 100 milliliters of saline weekly for 6 weeks, followed by 12 monthly treatments. If you follow these patients, you'll see that at 3 months, the complete response rate was 45%, and at a year is around 28%. So 62% of the initial responders, 62% of the initial 45% remained disease-free at a year later. Now, Jim McKiernan also spearheaded the effort of utilizing docetaxel. This is a phase 1 study of 18 patients who were truly BCG refractory. They got 6 weekly installations of docetaxel. There was no maintenance regimen initially in the phase 1 study. And what he found was that the initial complete response rate was 56%. There were 11% of partial responders, which we don't really look at that anymore. And about a third of the patients had no response. 4 out of those 6 patients underwent a cystectomy had non-invasive disease. So the 6 patients who had a cystectomy, 2 of them had muscle-invasive disease, and the other 4 did not. He then followed these patients and included more patients and actually added maintenance therapy. And what he found was that the complete response rate was maintained at 59% and followed these patients out. So at 1 year, the complete response rate was still maintained at 40%. And even at 3 years, it was 25%. As far as recurrence-free survival, he found a trend towards improvement, towards recurrence-free survival in those who got maintenance versus induction. There was no difference as far as longer-term survival or progression-free survival or overall survival between maintenance and induction. So that kind of led the effort towards looking at sequential intravesical therapy. And one of some of the earlier studies that have been published was by Ben Breyer and Badri up in San Francisco. So, you know, UCSF definitely had a big role in playing in the initial sequential therapies. And Ben actually looked at the first 10 patients that were BCG refractory or BCG intolerant. And what they did was they gave gemcitabine and mitomycin C. So they gave 1 gram of gemcitabine followed by 40 milligrams of mitomycin, 6 weekly installations followed by 12 monthly installations. What he found was that 6 out of the 10 patients were disease-free at 14 months. Now, right after this time, a couple things came to light. One was that there was a massive mitomycin shortage. So there was very little mitomycin floating around this time. And so they had to look for alternatives. And the best alternative at the time was gemcitabine for a couple reasons. Gemcitabine was readily available, it was generic, and it's significantly cheaper. So mitomycin is probably around $1,000 per vial. Gemcitabine, you're looking at less than $40. So people actually started looking at this. And so this was again spearheaded by Mike O'Donnell. And everybody was doing it independently. And so Mike O'Donnell, anytime a patient had BCG unresponsive disease, everybody would email Mike O'Donnell and he'd give them this regimen. And the data was never published. Everybody just, you know, looked at their own cohort, but no one published it. And it was at the PCAN meeting a couple years ago when Mike O'Donnell just asked all the investigators that attended to please submit their own data and their outcomes and see what it looks like. And people started doing it. And what you noticed was that the data was quite good. So they looked at 276 patients who were BCG unresponsive. 71 of them had CIS, 34 were papillary only. And what you'll see is that they don't have a complete response rate. They don't talk about it in the study, but if you actually look at the 1-year data, the carcinoma in situ patients at 1 year, 60% of those patients were still disease-free if they're CIS. If they're papillary disease, 1 year, it's 62%. If you follow these patients out to 2 years, the recurrence-free survival at 2 years is 43% for CIS and 51% for papillary tumors. So this has really been a game changer with how we treat patients with BCG unresponsive disease. Now, that was the mainstay until Pembrolizumab came into the foray after it got FDA approval 3 months ago. And the data, the drug was FDA approved based on the Keynote-057 study. They had 2 cohorts in the study, 130 patients with carcinoma in situ plus or minus papillary disease, and then they had a different cohort of 130 patients with papillary disease without CIS. Patients were given pembrolizumab every 3 weeks until they either had disease progression or recurrence, or until completion of the study, which was at 24 months. And what you'll first start seeing is that, 102 patients kind of met the criteria for cohort A. They were treated. What you'll see is that only 23% of only 23 patients, basically 23% of patients, are still ongoing. So that means the remaining 77, 78% had to discontinue. And they discontinued not because they were unable to tolerate disease. The vast majority of patients discontinued because they either had persistent disease or recurrent disease. 65% of the discontinuation was due to disease recurrences or persistence. Only about 8 or 9% of patients stopped secondary to adverse effects. And so what did the data look like? At 3 months, the CR rate was 40%. And the real plus from this study was that not a single patient progressed to muscle invasive disease. So, I mean, while we say that 60% of the patients failed the study, I think the positive spin towards this is that not a single patient progressed to muscle invasive or metastatic cancer. If you follow these patients out to a year, you'll see that 53% of the initial 40% were still disease-free at a year. So in essence, you're looking at about a 20% disease-free rate at a year. So let's go over some of the clinical trials. First, is the Adstiladrin. This is a recombinant adenovirus that actually harbors interferon alpha. And this has been spearheaded by Steve Borgen and Colin Dinney. There was an initial phase 2 study that was presented a year ago, and the most recent data was presented a few months ago at GU ASCO in San Francisco. They had 198 patients, 157 were enrolled, 107 patients had carcinoma in situ, 50 patients had papillary tumors. The efficacy population was 151 patients. And what you'll see is that 53% of the patients with carcinoma in situ were complete responders at 3 months. If you follow these patients out to 6 months, 9 months, and 12 months, you'll see that the recurrence-free survival for patients with CIS, BCG unresponsive disease is 24%. For papillary disease, it's much better because oftentimes that's a surgical disease and the initial resection may have been of use. 73% of patients were initially complete responders, but by a year you lost some, but still maintained 44% of patients as complete responders. Now, what about the patients who actually had a complete response? You'll see that 60% of the papillary patients maintained their complete responses a year later, and 45% of patients maintained their complete responsiveness at a year later. What's different between this and the Keynote study is that the Keynote study looked at a year since the initial response. Here, what they did was they actually looked at a year since the initiation of the study. So in essence, you're kind of comparing 9 months of Adstiladrin to 12 months of Pembro. So the numbers vary a little bit, but I would say that they're equivalent. The benefit of the Adstiladrin study is that the toxicity rates are significantly lower. There's no systemic therapy whatsoever. These patients come in and they get an intravesical therapy every 3 months for 4 treatments. It's quite benign, and you don't have to worry about all the systemic toxicities associated with immune-related adverse effects from pembrolizumab. The downside of it was that you did have about 5% of patients with CIS and about 6% of patients with papillary disease that progressed to muscle invasive disease. And so that is the downside. And it's not that the drug doesn't work, it's just that oftentimes these patients harbor occult disease that's a little more invasive, and we tend to miss it because you don't necessarily see what's underneath the mucosa, number one. But number two, oftentimes if you know, for those of you that treat patients with, you know, this disease, the whole bladder is just abnormal. Everything's red and you can't tell head from tails. You don't know whether something's abnormal or normal, and you can't keep taking patients to the operating room and re-resecting them all the time because they have terrible lower urinary tract symptoms. So it's understandable that these patients actually may harbor some disease that often goes missed. But the benefit of the Pembro study, the keynote study, is that you didn't have any patients that went on to metastatic disease. Now, this is a study that I'm spearheading. 803 is an IL-15 superagonist. There have been a number of studies that have shown that IL-15 tends to augment the natural killer response. And we sought out to do a phase 2 or phase 3 registrational study. And we had 80 patients in cohort A. These are CIS, BCG unresponsive disease. And then cohort B, these are papillary tumors without CIS that are BCG unresponsive. What's a little bit different with our study versus the others is that oftentimes you really can't tell whether a patient is going to be a responder at the initial 3 months. And so what we did was we allowed patients who had high-grade TA or CIS at 3 months to receive an additional 6 installations of ALT-803 plus BCG. If the patients had high-grade T1, or if they had or new CIS, then they were off the study. If they had low-grade TA, or if they had no evidence of any residual disease, then they were maintained on it. And these patients would get 3 installations, just like a maintenance study, for up to 18 months. The study turned out to be, the data seems to be quite significant. Our complete response rate at any time is 72%. Now, the truth is that at 3 months, the complete response rate is about 55%. We re-challenged those who were just high-grade TAs or CIS, and we found that half of those that initially didn't respond responded by 6 months. And if you follow these patients out to 6 months, then the complete response rate is maintained at 56%. Now, this is a comparison of the 803 study compared to some of the other studies out that I've talked about. So if you look at the valrubicin study of the phase 2 study, and then the phase 3 study that allowed for approval, Pembrolizumab, Vicinium, which was, I didn't really talk about it because it's probably not going to get FDA approved because it didn't meet many of the milestones. If you look at CR at any time, the N803 definitely outperformed everybody. If you follow these patients out to 6 months, again, N803 tended to do the best, and at 12 months, it's about 25%. Now, that 25% is about what Pembrolizumab is and what about Adstiladrin is. And so I think in the long run, while we have really a really good complete response rate initially at 3 months and 6 months, again, we're dealing with a cohort of patients that is bound to recur. And sometimes these patients, you know, undoubtedly recur at a year later. And again, our 25% is similar to the Pembrolizumab data in that these 25% were 25% after the 6-month evaluation. So initially, this is 18 months after starting therapy. So we may not be comparing apples to apples, but, you know, the data is good, but, you know, just caution. We looked at the papillary tumors and found, again, the complete responses were quite high, 78% at any time, and at 6 months was still 78%. We still haven't reached a median recurrence-free survival to date. Now, what are some of the other clinical trials? This is a really promising study by Jim McKiernan, where he gives patients cabazitaxel, gemcitabine, and cisplatin. You can't do it all in the same day. It's a little too toxic. So he brings patients in twice a week. And this has been really led by De Castro. And this is a paper that was published last month in the Journal of Urology. They looked at 18 patients with a median follow-up of 28 months. Now, these are really heavily pretreated patients. So the mean number of prior intravesical courses was 3.7. 50% of patients received intravesical therapy after failing BCG. And then 40% of patients who were BCG unresponsive were actually enrolled in a phase 1 clinical trial. So again, heavily pretreated. 33% of patients were T1 and 72% of patients were CIS. The data is very promising. The complete response rate initially is 89%. If you look at 1 year recurrence-free survival, it's 83%, and 2 years is 64%. If you look at all comers and compare them to those who received the maximum dose of CGC, cisplatin, cabazitaxel, and gemcitabine, the all comers obviously didn't do quite as well as those that received all treatment courses, in part due to toxicity, but still tells you that there's a dose effect. The more they got, the better they did. In that 18 patients, you'll see that 5 out of the 18 underwent a radical cystectomy, here displayed by the scissors, and then 6 out of the 18 ended up having recurrences. Now, I want to talk a little bit about cystectomy, and I know we talk about CIS, and people oftentimes say, no one dies of CIS, but this is a paper published 10 years ago. This is a multi-institutional study of patients, with 243 patients who underwent a cystectomy. 16% of patients at cystectomy were either TA or T0, but 36% of patients were actually muscle invasive, and 6% of patients were node positive. Patients with CIS, again, I can't overstate the implications of having BCG unresponsive disease with CIS and assuming that there's nothing underneath it. If you look at the Harry Her series, the Memorial series, is that patients who ended up getting an early radical cystectomy, they did significantly better than those who got a delayed radical cystectomy. And those who had superficial disease at radical cystectomy did significantly better than those who had invasive disease at radical cystectomy. And that leads us to the conclusion. When I talk about BCG unresponsive disease, I really talk about the past, the present, and the future. And if you look at what was available in the past, it was valrubicin, it was gemcitabine or docetaxel and BCG and interferon alpha. What we have available to us now is gemcitabine and docetaxel, sequential intravesical therapy. We have pembrolizumab, and next month the FDA is going to review adstiladrin, and N803. Hopefully we'll submit our data to the FDA in the next year. And obviously the triple chemotherapy schedule by Jim McKiernan of cabazitaxel, gemcitabine, and cisplatin. I think that's going to be a game changer in the future. And with that, I'll take some questions.
So thus far, we only have one question, which was asking about the differences between treatments. Now, considering all the data that's been presented, the question is, why isn't gemcitabine first-line therapy for high-grade, non-muscle invasive disease? Why give BCG at all?
Because we think that BCG with maintenance, again, like I showed in the initial study, that BCG with maintenance outperforms chemotherapy. And we think that especially for patients who are looking to have a more durable response, the BCG offers that. I mean, chemotherapy only works when chemotherapy is in the bladder. Once you stop the intravesical chemotherapy, there's no lasting effect. There's no durability. That said, I still treat patients with high-grade TA with intravesical gemcitabine. I give them an induction course followed by 10 or 12 monthly installations of gemcitabine.
We have a few more questions trickling in. One asks, I thought some earlier studies with intravesical cisplatin had high rates of anaphylaxis. What has changed?
I think our understanding of being able to postpone these intravesical therapies to a later time to allow the bladder to heal I think we're a little more cognizant as far as getting urine analyses prior to intravesical therapies, not giving it when they have gross hematuria or urinary tract infections. And so I think nowadays, we're able to give these intravesical therapies and maintain a relatively good quality of life. But again, if you look at Jim McKiernan's study, you see that the all comers don't do quite as well as those that got the maximum dose, and that's in part due to the fact that a fair amount had difficulty tolerating the maximum dose.
Okay, and there are two questions that are somewhat similar. How has BCG shortage affected your practice? And then another question that's similar, given current BCG dosing, are you using full dose at induction and maintenance or decreased dose? I'll just remind everyone who's posting questions to the chat to put them in Q&A.
So that's a really good question. Fortunate for me, I have fortunately for the patients who are getting their care at UCLA and a few other sites, Immunity Bio, the company that is performing the BCG unresponsive study, the 803, the ALT 803 or the N803, they also have a BCG naive study. So these are patients who are BCG naive. And what they do is they supply us with a full dose of BCG. So we don't actually have to go and get it. They supply us with the BCG, and these patients are randomized to either BCG alone or BCG plus 803. And these are for patients who have carcinoma in situ. These are BCG naive CIS patients. And so we don't really have an issue with BCG naive patients because we have access to that clinical trial. Now, if a patient has high-grade T1 and doesn't have CIS, then they don't qualify for that study. And in those patients, we try to give a full dose for induction, and then we cut the dose for maintenance. But lately, we've had such shortage issues that we've had no choice but to do a third dose for all patients for induction and maintenance. And then was there a second question associated with that?
I think you got both of those with response to full dose or decreased dose.
Yeah. And I don't know what the efficacy is going to be like with a third dose. I mean, there was an EORTC study that was published, about maybe 8 years ago, that found that for those with high-risk disease, third dose or 1 year of treatment was inferior to full dose in 3 years, whereas those with intermediate risk disease, a third dose or 1 year treatment was sufficient and just as good as longer therapies. That said, there wasn't a huge difference in progression rates between a third dose and a full dose.
Another question is, how does peri-op installation of intravesical gemcitabine for intermediate risk, a non-muscle invasive disease, affect failure outcomes?
Well, so Ed Messing published the data last year demonstrating that gemcitabine performed quite well compared to placebo. And, that was not surprising. We knew that gemcitabine does a little better than mitomycin and it's less toxic. And so we know that it reduces the chances of recurrences significantly. I think the hazard ratio on that study was about 0.4. So there was a 60% relative risk reduction for patients who got gemcitabine versus placebo.
There's a question regarding hyperthermia with intravesical chemo, the HIVEC mitomycin C, in non-muscle invasive disease versus BCG unresponsive non-muscle invasive.
Yeah, those are all studies that were in Europe. We don't have access to those. The data look promising. It's just, I haven't seen those studies really take off. I mean, it's not as though those studies have really changed practice in Europe. And that leads me to believe that there's probably a component of selection bias into those studies, and potentially having a really good surgeon. I mean, we tend to underestimate the role of the surgeon. We sit here and attribute, credit to some of these drugs, and we sometimes underestimate the role of the surgeon in really rendering someone complete response. I mean, we had the BCG naive study in which we enrolled patients who were BCG naive, either to BCG plus 803 or BCG alone. And I enrolled something on the order of 30 patients in the study, and I think it was like 200 plus patients. And the disease-free rate at a year and a half was 95% in both arms. So I think there's a role in how we manage disease now than before. I mean, I think we tend to be better surgeons because our cameras are much better. The Olympus cameras have beautiful visualization. You've got stores and their blue light equipment. We do restaging TURBTs. All those things have played a significant role, and I think they play a role in durable responses, irrespective of what study we enroll them in.
That actually is a good segue into a similar question. Have you noticed changes in practice pattern in surveying these patients now that we're using augmented cysto, either blue light, NBI, with every surveillance cysto? Are you using it only with CIS?
No, we have at UCLA, we have our flexible scopes are with narrowband imaging, so they're the Olympus set. And then in the operating room, we have, either the Storz equipment or the Olympus equipment. And I'll tell you, the flexible equipment in the clinic is far superior to the equipment in the operating room. The image quality of NBI is just phenomenal. I'm able to visualize every little detail of the bladder and able to see these small tumors that you couldn't see with a rigid scope. I think not because the rigid scope is worse than a flexible scope. I just think the camera quality, the high def quality, has really played a role in identifying these tumors, irrespective of narrowband and blue light. Now, I like narrowband in the clinic because you don't have to give any drugs and you can immediately turn on the narrowband filter with the press of a button. I think what it does for me is that it helps me identify, it creates contrast between the tumor and the bladder base. And so you can actually see the vascularity a little better, and you see just disorganized blood vessels forming. And those oftentimes tend to be associated with CIS or TA, high-grade TA tumors. The blue light, I think is a game changer as well. It really seems to help in the operating room. Oftentimes you have a hard time seeing these tumors because, again, I don't think the rigid equipment in the operating room is quite as good as in the clinic, and it tends to help.
There's one question about what is a recommendation for patients who are intolerant of non-BCG intravesical treatments? Would you change to another agent immediately?
Yeah, so if patients are unable to tolerate BCG, I then switch them over to, so if they're naive, I switch them over to gemcitabine. And the dosage of gemcitabine is 2 grams of gemcitabine, and I give them once a week dose for 6 weeks, followed by 10 weekly installations. Now, if they're BCG unresponsive and they have terrible side effects from BCG plus X, then I switch them to gemcitabine and docetaxel. Alternatively, you can always put them on Pembrolizumab or Adstiladrin. The Pembrolizumab is a systemic checkpoint inhibitor. It's an anti-PD-1. And Adstiladrin is a recombinant adenovirus that's non-replicating that you instill every 3 months into the bladder.
Are there recent advances in molecular markers to predict BCG response?
Yeah, nothing that is ready for prime time. There's definitely some work that's looked at whether FGFR3 positivity. There was a recent paper that was published that looked at this and found that it's not so clear cut. But yeah, people are looking at various molecular biomarkers as far as prediction of response to BCG. We actually had a BCG naive study in which this was a study that we had a while back. It was a vaccine that was supposed to be targeted for bladder cancer. It was supposed to come from the University of Michigan bladder cancer cell line. Unfortunately, the company got the wrong batch and ended up being a prostate cancer cell line. And so they developed like a vaccine for prostate cancer. but no one knew about it. And so they enrolled patients for BCG naives. It was a BCG naive study, and patients got low dose, medium, or high dose of vaccine, plus everyone got BCG. The good thing is that we collected urinary biomarkers on all these patients, 75 patients, and we got it before and during treatments, and we looked at about 112 urinary biomarkers. Really couldn't find anything. By far, the biggest predictor of someone responding to BCG is really counterintuitive. It's smokers. Smokers had a significantly improved response to BCG therapy than non-smokers. But amongst all the other biomarkers, urinary biomarkers, really couldn't find anything. And as far as genomics, that's still early, but maybe there's a role for FGFR3 as far as being a predictor of response or not.
This is a combination of a few different questions. What strain of BCG are you currently using in the current BCG shortage? And then also management strategies in areas that are unable to get BCG currently.
So we have TICE, and it's 50 milligrams, and so we've been cutting it into thirds. So it's 16.67. And again, for patients who may not have access to BCG, if they're located next to a medical center that has significant quantities of BCG, I would say refer those patients to that facility. If not, chemotherapy. Now, the problem with chemotherapy is that you have to have a pharmacy kind of adjoining your clinic where you can instill this. And so, you know, if you don't, then I don't know what to tell you other than maybe referring these patients to someone who does. But it really, there are gemcitabine, and again, I've had good results with gemcitabine in BCG naive patients. In BCG unresponsive, it's gemcitabine plus docetaxel.
A few people are asking, is there still a role for mitomycin C? And does MVAC have a role in this?
I don't really use mitomycin C. I think that it tends to have pretty significant effects on the bladder. I've had to take out a couple bladders because of mitomycin toxicity. You get this contractile, you know, walnut-sized bladder. And so between that and the fact that it's much more expensive, and the fact that gemcitabine, I think, is probably better than mitomycin, I don't really use mitomycin C that much. The only role that I use with mitomycin C is with a company that just got actually FDA approval. The company is Urology Pharma. Many of you just probably may have gotten the AUA Today blast. A couple days ago, they got FDA approval for UGN 101, which is their gel combined with mitomycin C. And that's been shown to be effective as a chemoablative agent for upper tract urothelial carcinoma. The company is also looking at doing a bladder cancer study for patients with intermediate risk bladder cancer, where the tumor is left intact and you put the gel in combination with mitomycin C. I think that's a little different because unlike giving 40 milligrams of mitomycin C, you're getting, you know, you get 40 milligrams of mitomycin C, you're getting a full dose and the whole bladder gets exposed to it. Whereas in patients in the UGN study, the Urology study, the mitomycin C is mixed with the gel and it slowly elutes out of the gel. And therefore you get a durable, you know, a longer response because the mitomycin C is slowly being released out of the gel and may have chemoablative effects without the toxicities. But again, you know, that's still experimental. They recently released their data, their phase 2B data, that showed that 65% of patients were complete responders of intermediate risk disease, where you left the tumor intact, and 65% of patients, the tumors were completely gone when you look back in there after 6 weeks. And most of those patients maintained, I think, at a year later, 85% of patients were still disease-free.
There are a few questions about technique with our TURs. Now, do you prefer monopolar, bipolar? You cauterize the base, blue light at first resection, And then specifically for high-risk disease, do you perform random biopsies?
So I use bipolar exclusively, and so I end up resecting the tumor entirely. I do a pretty aggressive TUR, and I know that because I was one of the early adopters of the gemcitabine study, and not gemcitabine study, but I was one of the early adopters of intravesical gemcitabine after after the JAMA paper was published. And out of my first 10 patients where I put intravesical gemcitabine, I had 2 patients develop complete alopecia. One was a woman going to her daughter's wedding, and another was a 50-year-old man with a full head of hair. So that led me to believe that, yes, maybe gemcitabine can cause alopecia, but probably more importantly, I probably did a really deep resection, and I caused microperforations. And so I think my TUR is a little more aggressive. With regards to blue light, yeah, I use blue light in patients who have continuous abnormal cytologies in fish. And the flexible scope in the office doesn't really show any identifiable lesion. I take the patients to the OR and turn on the blue light. For those patients, I try to find anything that looks remotely abnormal. And I do end up doing selective washings from each kidney. And I also do a TUR of the prostate at around 5 and 7 o'clock. You'd be surprised at how many patients actually harbor tumor in the prostate. It goes completely missed. We completely miss it.
There are a few questions about the timing of post-TUR installation with either gemcitabine or other agents. Which cases would you say that you use it versus not, outside of there being a frank perforation or concern for perforation of bladder at time of TUR?
So for patients who are intermediate risk, I would probably give them gemcitabine in the operating room, and then I would give them gemcitabine, as a maintenance regimen, induction and maintenance. I tend to give it immediately afterwards. I put a 3-way Foley catheter. I instill the mitomycin. I instill the gemcitabine, and I clamp that port. And then I have a pre-connected saline bag to the inflow port, but obviously I clamp it. And then about an hour and a half later, I ask the nurse to open up the outflow and saline wash the bladder. That's basically how I do it.
And there were a few questions reporting what is posted to the AUA website, which states that if BCG is not available, preferred alternative is mitomycin induction and monthly maintenance. Mm-hmm. Now, the question is, do you feel like this should be updated with gemcitabine or another agent?
I do. I think gemcitabine definitely has replaced mitomycin for 2 reasons. It's less expensive, and I think there's less adverse effects in the bladder. And I think the AUA is probably going to adopt sequential intravesical therapy for the BCG unresponsive patients.
And as a follow-up, would you recommend dose gem for maintenance for all BCG unresponsive patients?
Yeah, so the way that works is the GEM-DOSI study, the sequential intravesical, is they get 1 gram of gemcitabine in 50 milliliters of water, and then they get 37.5 milligrams of docetaxel and 50 milliliters of saline. They get it for you put the gemcitabine in for an hour, and then an hour and a half, you drain it, and then you put the docetaxel in for an hour, hour and a half, and then you send the patients home. They get it once a week for 6 weeks, followed by once a month for 2 years. So it is a 2-year maintenance schedule.
Now, this is more related to cost.
Mm-hmm.
Comparing costs between those who are getting more intravesical or systemic treatment compared to those going straight to radical cystectomy. I think this is including not just the index hospital session, but subsequent costs afterward.
Yeah, that's a great research question. Hollenbeck from the University of Michigan did look at some of this and found that that intravesical therapies are quite costly. And ultimately, a significant number of patients will end up going on to radical cystectomy. Now, that was in an era before some of these newer agents. That was in an era when we were giving BCG and interferon was very, very expensive. And so I could see why patients may, some may argue, at least from a third, from a societal perspective, that maybe doing an upfront cystectomy would be more cost effective. But the truth is a radical cystectomy is very expensive. The inpatient hospital stay is quite expensive. And it is, it's associated with quality of life differences for these patients. They may have to wear an illegal, a urine bag, or they end up having to be incontinent at night and have to wear condom catheters. I mean, there's some quality of life implications there. And so I don't usually attribute cost because there's such a huge difference in quality of life that you can't really, we could talk about qualities and quality of life factors, but it's hard to compare a cystectomy to intravesical therapy and cost being the primary driver. But that's a great research question. Probably warrants research. One of my fellows better work on it.
I know there may be people looking at it. One question was, in BCG unresponsive patients, do you challenge any of those patients with the second induction BCG before moving on to alternative treatment? And I guess which patients would you select for that option?
So that was so we designed the 803 study, the IL-15 superagonist that way. So if patients had, CIS or T1, and then at 3 months, we saw that they still had a little bit of CIS or they had some TA, then we re-challenged those patients with another 6-week course of BCG and 803. Those are the ones I would re-challenge. If they have high-grade T1, that bladder is screaming at you, telling you that it needs to come out. And if they develop new CIS, then those patients are probably not responding.
I think after this question, we may have time for maybe one more since we're coming close, or actually this may be the last. Is there a decrease in rates of cystectomy with these new medications? Do you anticipate this? The reasoning for that was it looks like the complete response rate is similar or the same across many of these agents.
Mm-hmm. Yeah, I mean, probably the most promising are the intravesical chemos, where you're able to maintain 40 to, the triple chemotherapy regimen, is looking at 80%, 40 to 70 to 80% responses at a year to 2 years. And so I think there would be a significant reduction in cystectomy rates in those patients. In those that are getting the Adstiladrin, those that are getting the Pembrolizumab, I think a significant number of those patients go on to radical cystectomy. And so not to say that they're not good. It's just, we think that the immune system can only, be stretched so far. And without a cytotoxic agent, it's unlikely to have a durable response.
Perfect. Thank you so much. We're close to the end of our time. I just want to remind all the participants that any questions that were not addressed will be posted on the website. So go ahead and keep popping in those Q&As if there are any more.
Okay. Thank you, Sam. Thanks, everybody.